Okay, welcome to day 2 of Ccrn. We're going to cover cardiovascular, pulmonary, and some multi-system things being burns, sepsis, and poisonings. Easy day today, easy day. Well, that was feedback. Okay, here we go. Cardiovascular. 29% cardiovascular. 29%. Very easy. You're going to see 58 little itty bitty baby questions. And 25 of them you won't be able to answer. Remember I told you that 25 questions you won't be able to answer? They're pretty much cardiovascular questions. So we're going to go through MIs, hypertension, shock, inflammatory disease, dysrhythmia, cardiac trauma, and that's what we're going to cover. First, let's start off with hypertensive crisis. Always one question on hypertensive crisis. And I'll have all the information here, but I'll just tell you what you need to know. And all this is in your handout, so you don't have to take any notes. There is essential hypertension, accelerated hypertension, and malignant hypertension. What differentiates these is what the diastolic blood pressure is. Accelerated hypertension is a diastolic BP greater than 120. Whereas malignant hypertension is its diastolic blood pressure greater than 140. You don't have to know for the exam this retinal hemorrhages business. All you have to know is the diastolic. Accelerated is a diastolic greater than 120 to 140. And malignant is a diastolic, a blood pressure diastolic, greater than 140. So if on the exam they say that someone's blood pressure is 242 over 142, that person has malignant hypertension. So that's easy. So that's one question in the bag. So any diastolic greater than 140 is malignant. Any diastolic greater than 140 is malignant. I say ADH, you say water. Some of the treatment when people have hypertension is vasodilators and sympathetic blocking agents, but the question that deals with hypertension is the diastolic. Anything greater than 140 is malignant hypertension. Easy as pie, questions in the bag. Now there's always one question on cardiomyopathy. They ask you about IHSS, idiopathic hypertrophic subaortic stenosis. So anyway, let's talk about cardiomyopathy. There's all different kinds. There's dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. You have this in your handout. Everything on the slide's in your handout. You don't have to take any notes. If you're right, you fail. Now, the only one you have to know really is the hypertrophic cardiomyopathy. That's the one they ask on the exam. Hypertrophic cardiomyopathy, known as HCM, or you could call it hypertrophic obstructive cardiomyopathy, HOCM, or you could call it idiopathic hypertrophic subaortic stenosis, IHSS. On the exam, they tend to use the initials IHSS. So now let's talk about idiopathic hypertrophic subaortic stenosis, which is the same thing as hypertrophic obstructive cardiomyopathy, which is the same thing as hypertrophic cardiomyopathy. Now, what is all this? All that this is a big fat ventricular septum. That's it. You got a big fat ventricular septum. And this ventricular septum hangs out into the left ventricle. So normally, your left ventricle fills up with like 70 cc's. But if you have a big fat ventricular septum, it hangs out into your left ventricle. So rather than your left ventricle filling up with 70 cc's, it only fills up with 30. Therefore, you have a reduction in cardiac output. You get lightheaded, you get chest pain, you get short of breath when you climb upstairs. And see, then you go to the doctor. You say, listen, I'm not feeling too good. I don't know, I walk upstairs, I get short of breath, I get dizzy, I have no energy, I have a little chest pain. He can't look at you and say, hey, you got a fat septum. give me $750. You wouldn't pay him a dime. Whereas if he says to you, well, you have idiopathic, hypertrophic, subaortic stenosis, you're like, wow, he's like the best doctor I ever met. So all that IHSS is, or HOCM, or HCM, all that it is a big fat ventricular septum that hangs out into your left ventricle, decreases the amount of blood in your ventricle, so during systole, you have reduction in cardiac output. On the exam, it says your patient has just been diagnosed with idiopathic hypertrophic subaortic stenosis. You know as a nurse that this results in a reduction of cardiac output. Which of the following pharmacological modalities would be instituted in order to improve cardiac output? Answer choice A is digoxin. Wrong answer. Don't give dig, can't give dig. No dig to these people. The reason being is you don't want to take that 30 cc's that's in the left ventricle and squeeze it out real quick and good, right? Because dig increases myocardial contractility. So you don't want to take the 30 cc's, the little bit of blood you have in your left ventricle, and go like this. Because then all the other cells in your body are like, hey, did you see any blood go by here? I think something just went by. So you can't use dig. You have to use something that squeezes the blood out like real slow, like this. So you take a little bit of blood and squeeze it out a long way. So you need like a beta blocker, like Inderal or something. You need like a beta blocker. A beta blocker decreases myocardial contractility, and it also slows down your heart. So that what happens is your ventricle is in diastole longer. So rather than filling up with 30 cc's, it'll fill up with 40. And then, because you're on a beta blocker, or sometimes they can use calcium channel blockers, that decreases myocardial contractility. It'll take your ventricle and squeeze the blood out real slow. Whereas you don't want dig. You don't want dobutamine. You don't want dopamine. You don't want nipride. You don't want any tridil, nipride, any kind of thing that vasodilates you don't want, right? You don't want any nitrates. Because see, if you have nitrates or nipride or anything that vasodilates, rather than 30 cc's going in the ventricle, you're only going to have like 10 cc's go in there because everything vasodilated and the blood pooled, and there's a decrease in right ventricular preload. So that you can't give any kind of dig. You can't give any kind of digoxin, dopamine, dobutamine. You can't give any vasodilative things at all. The only thing you really do is give a beta blocker or sometimes a calcium channel blocker like verapamil. Did this make sense at this hour in the morning? Oh, the things we do as nurses. All right, so now really the textbook explanation of what IHSS is or HOCM or HCM, to be more professional, it says it's the increased thickening of the heart muscle and septum. Really, it's primarily a septum. Inwardly at the expense of left ventricular chamber. All right, so your big fat septum hangs out into your left ventricle. Bing. Ventricles become rigid and stiff, and it restricts the filling and stroke volume and cardiac output. Okay. Beta blockers, calcium channel blockers, that's the treatment. And you got to stay away from digoxin, nitrates, dopamine, isoprel, morphine, that vasodilates. It's all contraindicated. So on the exam, when they say which of the following pharmacological modalities would increase the cardiac output in a patient with IHSS, you don't pick dig. You would pick a beta blocker, and usually it's Inderal or verapamil or one of those. So that's easy. So that's another question you're going to get correct. So malignant hypertension is a diastolic greater than 140. And this, you give a beta blocker or a calcium channel blocker. So that's two questions in the bag. Hey, a famous skier, Peekaboo Street. You ever hear of her? All right, so she's a famous skier. She's also a registered nurse. She's a nurse, and she works in the intensive care unit of a large metropolitan hospital in Utah. Anyway, she's no longer permitted to answer the telephone at work because it caused too much confusion. Whenever she would answer the phone, because she works in the ICU, she would say, "Peekaboo, ICU." And so she can't answer the phone in the unit. Not for nothing. What parent would call their kid peekaboo? You know, it's like, hello. All right, what do you think our next topic is? Swan dance. Swan dance, get it? There used to be a show like this on TV about 40 years ago. What was that called? Was it Concentration? Very good. All right, so we're going to do the Swan Gans. A little information about Swan Gans. Here we go. Swan Gans catheters. Always like 1 or 2 questions on Swan Gans catheters. Pulmonary artery pressure, right? Pulmonary artery pressure, and then you have the pulmonary artery wedge pressure. So you have a PAP and you have a PWAP or PCAP, depending on what you call it. You know, whenever you're looking at the pulmonary artery pressure, you have a top number and a bottom number. You have a systolic number, diastolic number. So that when the catheter is in your pulmonary artery, when your right ventricle is in systole, the blood comes out, and that's your systolic number. Then when the pulmonic valve closes, whatever the pressure is in this pulmonary artery, that would be your diastolic number. The systolic number is elevated in pulmonary hypertension, pulmonary hypoxia, COP, ARDS, and pulmonary embolism. And that would all make sense because during systole, your right ventricle is squeezing the blood out into the pulmonary artery. And if you have any kind of a lung problem, because your lungs would be in this area over here, right? These are your lungs. If you have any kind of lung problem, you have vasoconstriction and an increased pressure. And thus, during pulmonary artery systolic, when the right ventricle is squeezing the blood out into the lungs, if you have pulmonary hypertension, pulmonary hypoxia, COPD, ARDS, there's lots of vasoconstriction here. This will meet resistance, increase the pressure here, and your PAS will be elevated. The diastolic is elevated with any kind of heart problems, cardiac tamponade, left ventricular failure, and mitral valve disease. So then once the pulmonic valve is closed, there really should be a very continuous and open pathway from the tip of the catheter all the way to the left side of the heart. And so when the pulmonic valve is closed, the tip of this catheter really should be looking at what's going on the left side of the heart. So your PAD should really be reflective of the pressures in the left side of the heart. That's why when you have a heart problem, the PAD is elevated. When you have a lung problem, the PAS is elevated. So when you look at the pulmonary artery pressure, the systolic number, the diastolic number, systolic number is elevated, lung problems. Diastolic number is elevated when you have heart problems. All right. When you look at the pulmonary artery pressure, you know the normal pulmonary artery systolic is 20 to 30, and the diastolic is about 6 to 12. Some books say 8 to 14. It varies, but I say 6 to 12. So the top number is 20 to 30. The bottom number is like 6 to 12. And the PAD should really tell you what's happening to the left side of the heart. So if you don't always want to constantly wedge a catheter, you could look at the PAD. Not all the time, though. Sometimes it's not accurately looking at the left side of the heart. In other words, the PAD closely responds to the left side of the heart. That the PAD closely responds to the pressures in the left ventricle at the end of diastole. So that the PAD closely responds to the left ventricular and diastolic pressure, except in some conditions, right? If someone has a right bundle branch block, you cannot use the PAD to tell you what's happening on the left side of the heart, right? If somebody has a left bundle branch block. Oh, okay. So if someone has someone has a right bundle branch block, you cannot use the PAD to tell you what's happening on the left side of the heart. And not a lot, but some people have a right bundle branch block. And the reason for that is, you know, when you have a right bundle branch block, there is a delay in right ventricular systole. That with any bundle branch block, your ventricles do not contract at the same time. When you have a right bundle branch block, there is a big not big, but significant delay in right ventricular systole. Because there's a delay in right ventricular systole, this pulmonic valve stays closed longer than it should, and the blood in the pulmonary artery has a lot of time to drift off and dribble over to the left side of the heart. You see, a right bundle branch block results in a decrease and drop in pressure in your pulmonary artery because you didn't do systole yet. And because you have a delay in ventricular systole, there is a significant drop in the pressure in the pulmonary artery. Thus, the tip of this catheter will not accurately reflect the pressure in the left side of the heart. You can't use the PAD when people have mitral valve disease, and most people in the critical care environment have mitral valve disease. If you have a patient that has mitral valve disease, you can't use the PAD to tell you what's happening to the left side of the heart. You have to wedge the catheter. And the reason being is, let's say you have mitral stenosis. Mitral stenosis results in a mitral valve that is very, very stiff. And because it's stiff, it doesn't open too well. And if it doesn't open well, the blood from the left atrium has a hard time getting through that stiff mitral valve into the left ventricle. Thus, it results in an increased pressure in the left atrium. When you have mitral stenosis, your left atrium has to work really hard to squeeze the blood down into the left ventricle because the mitral valve is so stiff. So that mitral stenosis causes an increased pressure in your left atrium. This increase in pressure backs up to the tip of the catheter. Thus, when you have mitral stenosis, the tip of the catheter is not really telling you what's happening in the left ventricle. It's really reflecting the high pressure in the left atrium. Come on, all right? When you have mitral insufficiency, you can't use the PAD to tell you what's happening to the left side of the heart. Because when you have mitral insufficiency, you got a mitral valve that just don't close good. And when your mitral valve don't close good, whenever the left ventricle is in systole, rather than all the blood coming out of the aortic valve, some of the blood will back up through the incompetently closed mitral valve into the left atrium. Because you get a backflow of blood into the left atrium every time your heart's beating, this backflow of blood into the left atrium, because of an incompetently closed mitral valve, this backward flow of blood into the left atrium results in an increase in pressure over here. Thus, you're really not, measuring the pressure in the left ventricle. You cannot use the PAD if people have pulmonary hypertension. You can't use the PAD if someone has decreased left ventricular compliance. And most people in the critical care environment have a decreased left ventricular compliance. Most of them have stiff left ventricles. Because see, if I've got a stiff left ventricle, if I got a ventricle that's not compliant, I have an increase in pressure in that left ventricle. So if I got a ventricle that doesn't go with the flow, that stiff left ventricle, I wind up having an increase in pressure. I also wind up generating an increase in pressure in my left atrium as it's attempting to squeeze the blood down into the stiff left ventricle. This increase in pressure in the left atrium that is generated because of my stiff left ventricle, this increase in pressure backs up to this so that this is not going to adequately reflect what's happening in the left ventricle. So when you have decreased left ventricular compliance, because the atrium is having such hard time squeezing the blood down into the left ventricle, that pressure, increased pressure in the left atrium, is transmitted back to the tip of the catheter. Thus, it's not telling you exactly what the pressure is in the left ventricle. When people have aortic insufficiency, you can't use the PAD to tell you what's happening to the left side of the heart. Because see, if I have aortic insufficiency, I have an aortic valve that just don't close good. And if my aortic valve just doesn't close well, I'm supposed to say well, not good. Think about my husband's always correcting my English. It's like, I think he was an English teacher. Because I always say good. I'll say to the kids, "Wow, you did so good in school." My husband's like, "They did well. They did well in school." I'm like, you did good. Gonna walk around with a thesaurus. The other day we go out, right? Because I just got kids, because I'm too old to have my own, you know. So I have foster kids. I just got them in May, cute as could be. Jeffrey's 10 months, and Justin is, Steven's 5 years old, and Justin's 7. And then I have 2 twins coming in November, and another infant coming in December. So by December, I'll have 4 infants and a 5 and a 7-year-old. All right, but anyway, so people are saying, you know, since it's a stressful time, you need to make time for you and your husband, go out on a date, right? So I'm like, all right. So like every Friday night we go out on a date. We're home in like 2 hours. Anyway, so, well, I want to know how the baby is. Anyway, so I get all dressed up, right? I figure, oh, let me get dressed up like a little sex pot. So I wear this V-neck leopard top, and I thought I looked pretty good, you know? And I walk out of the bedroom, and he says to me, we're looking very meretricious tonight. So I'm like, what the? So me and the kids are looking, I'm like, I don't know what this means. All right, so he'll explain it to you later. So I'm thinking it sounds like a good thing, meretricious. Doesn't it sound like a good thing? I'm like, is that merit? Has the word merit in it? So I'm like, thank you, honey. See? He paid me a compliment. So anyway, we go out and eat, we come home, he goes to bed. So me, you know, I'm doing laundry, because that's all I do now with kids. All I do, laundry. And I can't imagine 3 kids could make so much laundry in my life. Me and my husband, I did laundry once a month. Now I'm doing like 2 loads a day. All right, so anyway, I'm doing laundry, you know, washing the kitchen floor, getting the breakfast ready, blah, blah, blah. And I said, you know, let me look up that word meretricious. And I went on the computer and looked it up. You know what meretricious means? Slut-like, whore-like in appearance. I'm like, Lord, it be. Who would ever think that would mean whore-like, slut-like in appearance? So then, 1 o'clock in the morning, I go in the bedroom, banging a pot in the pan. He's like, what are you doing? What are you doing? I'm like, how dare what you said to me? I look like a slut. And then not yesterday, the day before yesterday, he called me up on the phone, and sometimes I don't even know what he's saying. Anyway, he's saying something about something being limpid. So I got things to do, you know, I got kids, I got to get them ready for school. I got a million things to do in my life here, and he's talking about things being limpid. So I say to him, you know, you've got a limpid problem, you know, don't worry about it. They got medication for things that are limpid. So I don't know. You know what the word limpid means? Clear. He was talking about water. He just put this new breeder filter on the water, and he's talking about the water being limpid. I didn't know what he was talking about. But anyway, limpid means clear. I thought it was like a male dysfunctional problem. You know what I'm saying? Like, holy mackerel. All right, back to here now. All right, now. There's another word he just used. Deprecate. Yeah, and last night I'm on the phone with him. He uses the word deprecate. I'm thinking it sounds like a fecal word, you know, like a bowel movement kind of a thing. Wasn't it? A deprecate? And I was talking about the kids and something deprecated. So I'm thinking the kid pooped on the floor. I don't know. You know what deprecate means? Disapprove. You know, disapprove. Deprecate. I'm like, I don't understand what he's talking about half the time. Maybe that's why I'm married so long. All right, anyway. Here we go. So whenever you deprecate, like a fecal word. Here we go. Whenever you have aortic insufficiency, you can't use the PAD to tell you what's happening to the left side of the heart. Because whenever you have aortic insufficiency, you have yourself an aortic valve that just don't close good. And since it doesn't close good, you get a backward flow of blood. Blood flowing backward into the left ventricle prematurely shuts the mitral valve. Since the backward flow of blood into the left ventricle prematurely shuts the mitral valve, then you can't use the PAD to tell you what's happening in the left ventricle because your mitral valve shut prematurely. And if you have pulmonic insufficiency, you can't use the PAD. Because pulmonic insufficiency, you get a pulmonic valve that just don't close good. And if it don't close good, you get a backward flow of blood into the right ventricle. And if you have a backward flow of blood into the right ventricle, it reduces the pressure in the pulmonary artery because blood is going backwards. This reduction of pressure in the pulmonary artery then makes it so that the tip of the catheter is not accurately reflecting the pressure in the left ventricle. So there are certain conditions where you can't use the PAD to tell you what's happening to the left side of the heart. And that would be things such as right bundle branch block, mitral valve diseases, aortic insufficiency, pulmonic insufficiency. So really any valvular diseases and then right bundle branch block, and decrease left ventricular compliance, which almost everybody in the critical care area has. So in other words, most of the time you can't use the PAD to tell you what's happening to the left side of the heart. When you have a pulmonary artery waveform, you know that the pulmonary artery waveform will occur in the QT interval. Within the QT interval of the EKG, that's when you see the pulmonary artery waveform. The thing you have to know is whenever you take a reading, it always must be at the end of exhalation, right? It always has to be at the end of exhalation. And also, whenever a patient is breathing, you'll notice you'll get a dip in the reading, right? You'll always get a dip in the reading. When people are breathing, you'll get a dip. So when you have a pulmonary artery waveform pressure or even a wedge pressure and it starts dipping, that's a good thing. It means they're breathing. When you're looking at a pulmonary artery pressure, wedge pressure, whether you say it's a PAWP or a PCWP or PCOP, pulmonary capillary occlusion pressure, whenever you're looking at a wedge, the normal reading is 4 to 12. Some books say 6 to 12. Some books say 6 to 14. I use 4 to 12. So that the normal wedge is around 4 to 12. When you're looking at a wedge form, you'll notice that there will be A waves, C waves, and V waves. Within the reading, you'll see A waves, C waves, and V waves in a normal wedge. So you have an A wave, a C wave, a V wave, an A wave, a C wave, a V wave, an A wave, a C wave, a V wave. And you need to know that the A wave that you see is atrial contraction. It always occurs after the QRS. The C wave is mitral valve closing, of which you can hardly ever see. And the V wave is atrial filling, and you'll usually see that after the T wave. So when you're looking at a wedge, you get A waves, C waves, and V waves. I don't pay attention to C waves, I can hardly ever see them. But I do pay attention to A waves and V waves. In a wedge pressure, the A wave is atrial contraction, and the V wave is atrial filling. The A wave you see after the QRS, and the V wave you see after the T wave. Okay, so this is the EKG, and this is a wedge reading. This is your pulmonary artery wedge pressure. Whenever you're looking at this, it's important to identify the A waves, because to take the mean of all these waves is totally inaccurate. And that's what happens a lot in a critical care environment. People take the mean of all those waves. But that is grossly inaccurate. In order to get a correct pulmonary artery wedge pressure, what you have to do is you have to find the A wave and take the mean of the A wave, and that is the only accurate way of doing a wedge pressure. So now you're looking at all these humps and you say to yourself, well, what's an A wave? Well, the A wave occurs after the QRS. So what you have to do is you pick a hump. Pick a hump, bring it up, and notice I'm after the QRS, so therefore I have to be a A wave. And then what's this hump over here? It occurs after the T wave, so that's got to be a V wave. So we got an A wave, a V wave, A wave, V wave. Because A waves occur after the QRS, V waves occur after the T wave. Believe it or not, this is a wedge pressure. A lot of nurses would go to the phone and looking at this, and they'll say, the swan won't wedge. The swan won't wedge. And then in report, they're like, hasn't wedged since they put it in, all right? But it is wedged. This is a pulmonary artery wedge pressure. Now, how do you know? Well, you gotta pick a hump. Pick a hump and bring it up, and notice it occurs after the QRS. So this is the A wave. Pick a hump. It occurs after the T wave. So what's this? V. This cannot be a pulmonary artery pressure wave, because if it was a PAP, it would occur within the QT interval of the EKG. The fact that this occurs after the T wave, this is a V wave, this is a A wave. to get the correct wedge pressure, you just take the A wave and measure the A wave. Right? That's how you do it. And here they're saying it's like 27 over 24, and so the mean would be like 25. So the wedge is 25. Because if you took a mean of all this, you would get a very horribly high wedge pressure. So the only accurate way of doing a wedge pressure is you find the A wave. And where would you find the A wave? After the QRS. And then you take the mean of the A wave in order to get an accurate wedge reading. Tell you, it makes you want to go back into work, doesn't it? Not really, eh? Pulmonary artery wedge pressure. The normal is 4 to 12. It's elevated in mitral stenosis, mitral insufficiency, cardiac tamponade, constrictive pericarditis, left ventricular failure, volume overload, so that your wedge pressure, which is reflective of the pressure on the left side of the heart, is elevated with any kind of heart problems, whether it be valvular disease, cardiac tamponade, left ventricular failure, volume overloaded, and that's when your wedge would be elevated. Good. Now your PAD, right, the PAD usually correlates with the left ventricular end diastolic pressure. That, right now this balloon is inflated, but if this balloon was deflated and this pulmonic valve was closed, the tip of the catheter, there's an open channel from the tip of the catheter to the left side of the heart. So ordinarily the PAD is looking at the pressure on the left side of the heart. Except, of course, if you have a right bundle branch block, mitral valve disease, pulmonary hypertension, decreased left ventricular compliance, pulmonary or aortic insufficiency. So now the PAD correlates with the left ventricular end diastolic pressure. The PAD correlates with the wedge pressure, because your wedge is looking at what's happening on the left side of the heart. And your wedge correlates with the left ventricular end diastolic pressure. In other words, your PAD, your wedge, and the left ventricular end diastolic pressure should all pretty much be the same. There's just those certain conditions where the PAD won't tell you what's happening to the left side of the heart, and that would be right bundle branch block, mitral valve disease, pulmonary hypertension, decreased left ventricular compliance, aortic pulmonic insufficiency. Now the mean of the A wave, which I showed you, you find the A wave, it occurs right after the QRS. The mean of the A wave, which is the wedge, will approximate the left ventricular end diastolic pressure and also the PAD when blood flow through the lungs is unobstructed. And that knowledge of the end diastolic pressure of the left ventricle will provide a means of assessing how well the left ventricle functions as a pump. So whether you use the PAD or you use the wedge, it tells you what's going on with the left side of the heart. Just for your information, the wedge is always a little bit lower than the PAD. So, right, it's always 1 to 4 lower than the PAD. You should never get a wedge higher than your PAD. You can't. I mean, if you are, it means something. So I can't have a value of 28 over 14 and have a wedge of 16. I can't. My wedge can never be higher than my PAD. And that's because the wedge can never be higher than the PAD, and that's because blood flows from a higher to a lower pressure in order to move forward. So can I have a pulmonary artery pressure of 32 over 12 and then have a wedge of 16? No, I cannot have a wedge higher than my PAD. The discrepancy is caused by either over-wedging or some kind of physiological condition, meaning that the catheter is in the wrong zone. When your catheter is in the wrong zone, you're going to have a wedge that's higher than your PAD. And what do we mean by zone? Well, you take the lung and you divide it up into 3 zones. Zone 1, Zone 2, Zone 3. Catheters must always be in Zone 3. Here we go, another better picture. Right now, this catheter is in Zone 3. If the catheter is in Zone 1, there's no clear channel looking at the left side of the heart. In Zone 2, only during, I believe, diastole, can you look at the left side of the heart? And then you see in zone 3, you can always have an open channel, and it's always looking at the left side of the heart. So in zone 3, the catheter tip reflects left atrial pressures and thus reflecting the left ventricular and diastolic pressure. So the catheter must be in zone 3, and this would be confirmed by an X-ray. By an X-ray, they'll confirm that it's in zone 3. Although you could usually tell that it's not in the right zone because you have a very dampened waveform. Even though you're pulling that twanger, it's still like not good and crisp and clear. Or maybe your wedge is higher than your PAD. That would mean it's not in the right zone. Or maybe you can't discern A waves and V waves when you're doing that wedge. You don't have good A waves and good V waves. That's also an indication that the catheter is not in zone 3. Or maybe whenever the patient's breathing, you get like waveforms all over the place. You ever see that? It's like, whoa, like this, it's looking crazy. Well, that usually means that it's in zone 1 or 2 and not in zone 3. So how do you know it's in zone 3? Well, look at this. How do you know it? Oh, well, how do you know the catheter is in zone 1 or 2 where it's not supposed to be? Damped wedge tracing. You have a wedge pressure higher than the PAD. Absence of A waves and V waves, or that they're difficult to see, and marked respiratory variations. And this all tells you that the catheter is in the wrong zone. It has to be in zone 3. If it's in zone 1 or 2, then you'll get these things: dampened waveform, wedge higher than the PAD, absence of A waves and V waves, and lots of marked respiratory variations when the patient's breathing. Okay, calculating the wedge on PEEP. You know, when someone's on PEEP, if they're on PEEP greater than 10, any PEEP greater than 10 affects your wedge. So if you have someone on PEEP greater than 10, and you get a wedge, that's not going to be an accurate recording. Now, PEEP is measured in centimeters of water, and the wedge is measured in millimeters of mercury. So how do you measure the PEEP? The wedge when someone's on PEEP? Very, very easy. First, you have to change the PEEP, which is centimeters of water, into millimeters of mercury. Then you got to divide the PEEP by 1.36, and then you got to divide it again by 2. Sounds confusing, but what? It's very, very easy. You got to remember right now 1.36, and you got to remember 2. That's what you have to remember. 1.36. And remember 2. Those are the numbers you have to remember. That you have to divide something by 1.36, and then you have to divide it again by 2. So that PEEP, someone's on a PEEP of 15, okay? Your patient is on a PEEP of 15. And when you take the wedge, you get a wedge of 18. Now that wedge is not an accurate wedge because he's on PEEP greater than 10. He's on a PEEP of 15. So therefore, you got to do some calculation. What you have to do is, you have to do 1.36 times 15. And by doing that, you'll get 11. Right? So you do 1.36, not times it, divide it. 1.36 into 15, and you get 11. And then you take the 11 and divide it by 2, and you get 5.5. So the numbers you got to remember is 1.36 and 2. So you take the PEEP that the patient's on, divide it by 1.36. You get 11. Take the 11, divide it by 2, you get 5.5. So that if he's on 18 of PEEP, if 18 is his wedge, you got to subtract 5.5 from your recorded wedge in order to get your true wedge, which is 12.5. So the two numbers you got to memorize is 1.36, and you got to remember 2. So for example, someone's on a PEEP of 20, and you have a recorded wedge of 22. I want to know their true wedge. What's their true wedge? 22 is not the true wedge because he's on a PEEP of 20. Any PEEP greater than 10, you must do this mathematical equation. And so we're going to take 20, divided by 1.36. And you come out with 14. And then you take the 14 divided by 2, which gives you 7. And I take the 7 and I subtract it from my recorded wedge in order to get my true wedge, which would be 15. I have someone on peep of 14, which is greater than 10. So therefore, I got to do my math. So I take 14, I divide it by 1.36. Then I get 10. And then I divide that number, which is 10, by 2, and I come up with 5. So then I use the 5, and I take it from my recorded wedge, right? I subtract 5 from my recorded wedge in order to get my true wedge. So even though you were thinking it's 12, it really is 7. So the two numbers you got to remember are 1.36 and 2. I have somebody on a peep of 18. They're on a peep of 18. So I take that 18 and I divide it by 1.36. And I come up with 13. And then I take the 13, I divide it by 2. And I come up with 6.5. I take the 6.5 and I subtract that from my recorded wedge in order to get my real wedge. So you thought it was 16, you thought he might have been going into failure, when really he's absolutely normal. It's 9.5. You have somebody on a peep of 16. If they're on a peep of 16, that's greater than 10. So now you got to do the math. A peep of 16, you got to divide that 16 by 1.36. Good. And when you do that, you come up with 11. And then you take the 11 divided by 2, which is 5.5. I take the 5.5, I subtract it from my recorded wedge of 11, and I come up with a wedge of 5.5. So even though you recorded it at 11, and you think that that's a great number, it's really 5.5, his true wedge. He's really depleted in fluid. So the numbers you have to memorize are 1.36, and you got to memorize 2. So you're going to look at how much peep the guy is on. If he's on any peep greater than 10, you're going to divide that by 1.36. Then you divide it again by, and you take that number and subtract it from your recorded wedge in order to get your true wedge. Good. Any diastolic greater than 140 is malignant. Okay, so we're going to play What's My Disease? Here we go. You got somebody with a pulmonary artery pressure, PAP of 58/34, a wedge of 2, a right atrial pressure of 18, and cardiac output of 3. What's my disease? What do you think? Well, you got a high pulmonary artery pressure, so you definitely have something going on in the lungs. You have a low wedge pressure, high pressure on the right side of the heart, little low cardiac output. So I would say that this is somebody with COPD, right, or COPD, somebody with pulmonary hypertension, and they overdosed on Lasix, or they're intravascularly depleted. Here you go. You got somebody 28/8, a wedge of 8, a CVP of 7, and a cardiac output of 4. And what do you think of that? And you would say that is absolutely normal. Very good. All those are normal parameters. Here you go. Somebody with a pulmonary artery pressure of 48/24. And that's a little high. Got a wedge of 22. That's high. Right atrial pressure 14, that's high. Cardiac output is low. So what's happening to this patient? And you would say, probably biventricular failure. We have an elevated wedge, so we have failure on the left side of the heart. Failure on the left side of the heart's backing up into the lungs, thus giving you a high pulmonary artery pressure, pulmonary edema. And then it's continuing to back up into the right side of the heart. So now you have not only left-sided failure, but also right-sided failure, biventricular failure. 21/6, you have a wedge of 4, a right atrial pressure of 2, and a cardiac output of 2. What do you think is happening to this person? And you would say hypovolemia, right? Some kind of hypovolemia, or maybe even probably like a shock, right? Probably shock. 2 liters, cardiac output shock. Hypovolemic or hemorrhagic shock is going on. 38/26, a wedge of 12, and a CVP of 8, and a cardiac output of 4. So cardiac output's okay, right atrial pressure is all right, but the wedge of 12 is okay. So you just have a high pulmonary artery pressure, so what could that be due to? And you would probably say, like atelectic tissue. You know, maybe the guy just got out of the OR and was in the OR for 8 hours and just has a little atelectic tissue. Atelectasis would give you a high pulmonary artery pressure. Can't be a pulmonary embolism, because a pulmonary embolism would affect the pressure on the right side of the heart. And it can't be, what else? Well, you could probably say COPD, but no, it really can't be COPD, because that's long-standing and you would have a higher pressure on the right side of the heart. Because the right side of the heart is normal, it means that it's a condition that just occurred like today. It can't be a pulmonary embolism, though, because the pressure on the right side of the heart is normal. So it has to be like an atelectic tissue event. Heart murmurs. Always 2 questions on heart murmurs. Watch how smart you are. There'll be no living with you. So if somebody's on a PEEP greater than 10, and you got to do a wedge, what are you going to do? You're going to take the PEEP, divide it by 1.36, divide it again by 2, take that number, subtract it from the recorded wedge in order to get the real wedge. Whenever you're going to do a wedge pressure, you have an A wave and you have a V wave. A waves are found after the QRS. V waves are found after the T wave. To do an accurate wedge, you have to take the mean of the A wave. Good. Makes you want to go into work, doesn't it? Oh, who's saying no? All right, here we go. Have to start a little business on the side. I have this, those of you that don't know it, I have this unique way of doing ABG interpretation, you know? And so you have my full permission to take it verbatim, okay? There's enough food for everybody. And put on a tape and sell to nursing students. They would definitely buy that. If you ask nursing students what's the hardest thing about nursing school besides nursing diagnosis, they'll always tell you ABG interpretation. Whenever they take it in school, the nursing professors, they're like, oh, the arrow's going up, arrow's going up, 2 arrows go down, it's metabolic, one goes up, one goes down, it's this. And anyway, the nursing students get all confused. So take my technique, you have my full permission to take it verbatim, put on a tape and sell it to nursing students. They would definitely buy this, you know, for $9.95, $9, sell it for $9.95. Their nursing textbooks run about $155 for a Luckman and Sorensen. So to sell an ABG tape, $9.95, forget about it. You know, there's 1,500 nursing schools throughout the United States. You send out a flyer to these nursing schools and you say, hey, be a hidden clinical. Everything you always wanted to know about ABG interpretation, but didn't want to ask your nursing professor because you didn't want her to think you were stupid, else she'd give you a bad mark on your care plan or whatever. Anyway, you send out the flyers to 1,500 nursing schools. I bet you get at least 10 orders for school easy. For $9, you don't think nursing students are going to buy that for $9.95? It's a bargain. Of course they're going to buy it. At least 10 students. They buy everything. Nursing students buy. Oh, especially if you put on the bottom, you know, guarantee you pass the state boards by using this tape. Oh, forget it. They'll buy it in a minute. And so if you get 10 orders per school times 1,500 nursing schools, that's 15,000 orders. 15,000 orders at $9.95 brings in what? $150,000 in the fall and $150,000 in the spring. You'll be pulling in $300,000 for a stupid little ABG tape. No? Who's from the Philippines? Wait, that's a stupid, what a stupid question that is. Who's not from the Philippines? All right, so anyway, my friend is from the Philippines, so every year she has to bring me on this like 30-hour trip to get there, you know? It's like, oh. Then once I'm there, I call my husband. I'm like, listen, I'm not coming home. I can't possibly take that ride home, all right? But anyway, as we walk through the Philippines, she knows everybody, right? She knows everybody. She knows everybody. Everybody. And hello, how you doing? How you doing? She drags me all over the place. Everybody I meet in the Philippines is a registered nurse. Everybody. Everybody's a nurse. The mothers, the fathers, the sisters, the brothers. Everybody's a nurse. I've never met anybody non-nurse. Everybody's a nurse in the Philippines. I'm thinking, you know, people in the Philippines make that tape, sell it over there. You make like $1 billion, you make $1 million, $5 million. Heart murmurs. Okay, so now there are two common causes of a murmur, right? Two common causes of a murmur. The first cause of a murmur would be the forward flow of blood. The forward flow of blood through stiff stenotic open valves. So one cause of a murmur would be the forward flow of blood through stiff stenotic open valves. Whenever you have valves that are all stiff and stenotic and don't open too good, the blood going through that narrow lumen will give me a murmur. So the first cause of a murmur would be the forward flow of blood through stiff stenotic open valves. So that whenever I say the word stenosis, you know that that murmur is made when that valve is open, or it's supposed to be open. So if I say stenosis, you say open. Stenosis. Open. So if you read in somebody's chart that they have the murmur mitral stenosis, that tells you that that murmur was made when that mitral valve was supposed to be open. I mean, it is open, it's just not open too good. So I say stenosis, you say open. Another cause of a murmur would be the backward flow of blood. The backward flow of blood through valves that are incompetently closed. Whenever you have heart valves that just don't close good, the blood goes backwards through and gives you a murmur. And that's known as insufficiency. So if you're reading in somebody's chart that they have the murmur of aortic insufficiency, that tells you that that murmur was made because that aortic valve wasn't closed good, and because it wasn't closed good, the blood went backwards through it and gave you a murmur. So if I tell you that someone has pulmonic insufficiency, that tells you that that murmur was made when that pulmonic valve was supposed to be closed. So I say insufficiency, you say? I say stenosis, you say? Good. Learning has occurred. Lord. You know, whenever you listen to a murmur, you got to be in the right place. If you're not in the right place, you're not going to hear it. So you must be in the right place. Aortic area is heard on the right side, which is very confusing because your aortic area is on the left side of your heart, and yet you hear it on the right side of your chest. It's because you hear the murmur where the heart valve sends the blood. So the aortic area is heard on the right side, second intercostal space. Pulmonic area is heard on the left side, second intercostal space. Then you have the mitral valve area, which is the fifth intercostal space, mid-clavicular line. And then you have the tricuspid area, is the fourth intercostal space, left sternal border. So you have aortic area, pulmonic, mitral, aortic, pulmonic, mitral, tricuspid. Aortic, pulmonic, mitral, and tricuspid. And you got to be in those places, else you're not going to hear it, the murmur. So for example, I come out of my patient's room and I say to my friend, this guy has aortic insufficiency. You can hear from the cafeteria. She's like, oh my God, let me hear, let me hear, let me hear. So she goes into the room, she has a stethoscope, she has it all over his chest. She's all over him. She's all over him, and she's looking at me going, meaning she can't hear anything. I go in there, she's over here. So I take her hand, right, and I go, like this. Then she's like, now she hears it. So you gotta be in the right place. Aortic murmurs, pulmonic, mitral, tricuspid. You gotta be in the right place, else you're not gonna hear it. Whenever you listen, it gotta be very systematic. It has to begin at the aortic area and then go to pulmonic, mitral, and tricuspid. Systolic murmurs, diastolic murmurs. It's important to know when a murmur is a systolic murmur and when it is a diastolic murmur, because to identify when it's a systolic murmur or when it's a diastolic murmur, it allows you then to make the music in your head, so when you go into the room, you can identify the murmur very, very easily. Diastolic murmurs are lub-dub murmur. Lub-dub murmur, lub-dub murmur. Systolic murmurs are lub-murmur-dub, lub-murmur-dub, lub-murmur-dub. And the reason why this is like this is because diastolic murmurs occur when the ventricles are in diastole. You know that an S1 is a closure of the mitral tricuspid valve. So an S1 closure, mitral tricuspid valve. After your mitral and tricuspid valve closes, your ventricles are in systole and you squeeze the blood out. Then your aortic pulmonic valve closes and you get an S2. After your aortic pulmonic valve closes, right after the aortic and the pulmonic valve closes, you get an S2. That's when your heart's going to fill. And when your heart's going to fill, that's during diastole, and that's when you hear a diastolic murmur. So diastolic murmurs are lub-dub murmur, lub-dub murmur, lub-dub murmur. Systolic murmur occurs during systole. Systolic murmur occurs when the ventricles are in systole. So that in a systolic murmur, you'll get lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. S1 is the closure of the mitral tricuspid valves. Whenever the mitral tricuspid valve closes, you get an S1. Then, after your mitral and tricuspid valve closes, you get S1. Then you're going to squeeze the blood out of the heart during systole. That's when you hear a systolic murmur. And then after all the blood's out of the heart, the aortic pulmonic valve closes and gives you an S2. So a systolic murmur is lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. A diastolic murmur is lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. So I'll do the murmur, you tell me. All right, don't look. I'll do the murmur, you tell me whether I'm systolic or diastolic. Lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. Systolic. Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. Diastolic, very good. You're reading somebody's chart that they have the murmur of mitral stenosis. You say to yourself, mitral stenosis is the murmur that is made whenever the mitral valve is open. Because I say stenosis, you say I say insufficiency, you say closed. So you read in somebody's chart that they have the murmur of mitral stenosis. You say to yourself, mitral stenosis is the murmur that is made whenever the mitral valve is open. And when's that mitral valve open? When is your mitral valve open? When the blood's popping from the left atrium down to the left ventricle. So your mitral valve is open during diastole. Therefore, mitral stenosis is a diastolic murmur. Going to go into the patient's room, and what are you going to be singing? Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. You're reading somebody's chart that they have the murmur of aortic stenosis. You say to yourself, aortic stenosis is a murmur that is made whenever the aortic valve is open. I say stenosis, you say open. So aortic stenosis is a murmur that is made whenever the aortic valve is open. When's the aortic valve open? During systole. Therefore, it's a systolic murmur. You're going to go into the patient's room, and what are you going to be singing? Lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. You're reading somebody's chart that they have the murmur of pulmonic insufficiency. You say to yourself, pulmonic insufficiency is a murmur that is made whenever the pulmonic valve is supposed to be closed. When's that pulmonic valve supposed to be closed? During diastole. Therefore, pulmonic insufficiency is a diastolic murmur. You're going to walk into the patient's room, and what are you going to be singing? Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. Makes you want to go into work. Here we go, mitral stenosis, and we said it's a diastolic murmur. And we figured that out because when we said to ourselves, mitral stenosis is a murmur that's made whenever the mitral valve is open. When is your mitral valve open? And you said during diastole, therefore it's a diastolic murmur. So you're going to go into the patient's room, and you're going to be singing lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. Now, the murmur of mitral stenosis is rumbling. Every medical book will describe it as rumbling. You don't have to know it's crescendo or decrescendo or any of this nonsense. It's just a bunch of rumbling. That's what it is. And the causes would include calcification of leaflets, but it's a rumbling noise. And what you're going to hear is lub, dub, rumble, lub, dub, rumble. Lub, dub, brr, lub, dub, brr, lub, dub, brr, lub, dub, brr. You do it. Hit it. Good. A lot of nurses think it's water in the ventilator tubing. You know when you have people on a ventilator, and you're listening, lub, dub, brr, lub, dub, brr, And they always think it's water in the tubing. They're like, you know, I've been doing this all day. I just can't seem to get that noise out. Here we go. Aortic insufficiency. You're reading somebody's chart and you notice that they have aortic insufficiency. You say to yourself, aortic insufficiency is a murmur that's made whenever the aortic valve is supposed to be. And when's the aortic valve supposed to be closed? During diastole, therefore it's a diastolic murmur. I'm going to go into the patient's room and I'm going to be listening to lub-dub murmur, lub-dub murmur, lub-dub murmur. Aortic insufficiency is a blowing noise. It sounds like this. Lub-dub. I'm spitting my candy, sorry. Lub-dub, 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 lub-dub. All right, you do it. Usually little old ladies get aortic stenosis, right? Because whenever you're old, the calcium comes out of your bones and hangs around your aortic valve. So little old ladies tend to have aortic stenosis. And if you're reading somebody's chart that they have aortic stenosis, you say to yourself, aortic stenosis is a murmur that is made whenever the aortic valve is open. And when is the aortic valve supposed to be open? During systole, therefore it's a systolic murmur. You're going to go into the patient's room, and what are you going to listen to? Lub, murmur, dub, lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. Now, this murmur is holosystolic, which means it occurs all throughout systole, or pansystolic. And because it occurs all throughout systole, you don't even hear the lub-dub. All you do is hear the murmur. That's it. You're just going to be hearing the murmur. And what you're going to be hearing is a very harsh noise. Very harsh, horribly harsh. And it radiates all over the place. You do it. Hit it. That's aortic stenosis. And little old ladies always get the aortic stenosis. It includes calcification of the valves and rheumatic heart disease, but little old ladies always have aortic stenosis, and they always have atrial fib. If you ever hear atrial fib, it's very irregular, right? AFib, very irregular. And if you're a little old lady with AFib and aortic stenosis, it sounds like this. Sounds like that. And nurses always say, it's scattered rhonchi. Like, you know, I've been sectional all day long, I just can't seem to get that out. I'm like, you keep disconnecting from the ventilator, it'll go away. Mitral insufficiency, hit it. You're reading somebody's chart that they have the murmur mitral insufficiency. You say to yourself, mitral insufficiency is a murmur that is made whenever the mitral valve is supposed to be closed. When's that mitral valve supposed to be closed? During systole. Therefore, it's a systolic murmur. It happens to be a holosystolic murmur, which means you hear it all throughout systole, and it's blowing. Every medical book will describe it as blowing, and it radiates. And here on the slide here, it says increases with squatting, although you wouldn't ask anybody to get out of bed and squat for you. But so when people have mitral insufficiency, it's you do it, hit it. Keep going until you pass out. You want to? Should do that if you have kids. Not that I'm an expert. I only had kids for like a little while now, but I found that when I hyperventilate them, it's a good thing. Like, let's say you have like a little temper tantrum or whatever. I'm like, okay. I'm not going to argue with you, okay? If you want to stay up, 15, half hour longer, you have to take 75 very deep breaths for me, okay? And then I'll let you stay up. Then I lie in bed and we all take big breaths, right? And I say, I count, you breathe, all right? I'm going to lower the TV. I'll count, you breathe, all right? 75, then I'll let you stay up. You stay up to midnight, all right? All right, let's go. First breath. Now blow it out. Do it again. Blow it out. They're not even up to 44. They're out like a light. You make them so alkalotic, they're like numb. They're like that. Okay, so mitral insufficiency, some of the causes could be a myocardial infarction, rheumatic heart disease. So that if you're taking the test, right? If you're taking the test and you read that someone has mitral stenosis and they want to know what kind of murmur it is, you would say mitral stenosis is a murmur that's made whenever the mitral valve is open. And when's the mitral valve open? During diastole, therefore it's a diastolic murmur. How easy is this? Oh, here's back to swans here. This is a little misplaced, but this is a pulmonary artery wedge pressure. And how would you know? Well, you find a hump. Let's say I pick this hump over here, and I bring it up, and it's after the T wave. So this got to be a V. This got to be a wave because it has to come after a QRS. And so then to find the accurate wedge, I have to take the mean of the A wave, right? I got to take the mean of the A wave in order to get an accurate wedge. Good. Here's another picture, A waves and V waves. And how do you know, like look at this hump right after the QRS, this hump right after the T wave. A wave, V wave. Very good. And then this picture we showed already, right? A wave, V wave, right? Because after the T wave. And you just take a mean of the A wave. That's how you get an accurate reading. Now, to talk about 12 leads, they do have 12 leads on the exam now. Very, very easy. You just have to know that lead 1 and AVL are looking at your lateral wall. Lead 1 and AVL look at the lateral wall. Because lead 1 and an AVL, the sticky in the left arm is positive. And it's a positive sticky that looks at your heart. So that lead 1 and AVL are looking at the lateral wall, right? Lead 1, AVL looking at the lateral wall. And whenever the wave of depolarization, or whenever the electricity is going through the heart towards the positive sticky, your complex will always be up. That's why whenever you're looking at lead 1 and AVL, you're looking at the lateral wall leads, because the positive sticky looks at the heart. And looking at 1 and an AVL, the complex should always be going up, because whenever the wave of depolarization or the electrical activity goes towards the positive sticky, your complex is up. If you're looking at 1 and AVL, your lateral wall leads, and you notice that your complex is initially positive, then the complex gets initially negative, it tells you that the electricity is going away from the positive sticky. And if I am going away from the positive sticky, which is on the left arm, I must be going over to the right, and therefore any configuration like that in leads 1 and AVL would mean your patient has a right axis deviation, right? Be dramatic at work. $20 an hour, you should be lucky to show up. 2, 3, and AVF, look at the inferior wall. Lead 2, lead 3, and AVF, right? 2, 3, and AVF, left leg positive. Therefore, 2, 3, AVF, if the left leg is positive, we're looking at the inferior wall. So 2, 3, and AVF are looking at the inferior wall. Whenever the wave of depolarization goes through the heart, it should be going through in this direction. When it's going through this direction towards your positive sticky, your complex goes up. If I'm looking at lead 2, 3, and AVF, and I notice that my complex is initially positive, but then gets very negative, it tells me my electricity is going away from the positive sticky. If I'm going away from the positive sticky, I must be going up towards the left. So that if I have somebody with a configuration like this and leads 2, 3, and AVF is known as a left axis deviation. So 1 and AVL, look at the high lateral wall. 2, 3, and AVF look at the inferior wall. So that's easy. V1 through V6, your anterior septal lateral wall leads. V1, V2, V3, V4, look at the anterior septal wall. V1, V2, V3, V4, look at the anterior septal wall. V5 and V6, look at your lateral wall. So that's easy. And here's how you're supposed to look. You'll notice as you go from V1 through V6, you should always have the presence of a R wave, right? R wave. And your R wave gets bigger as you go from V1 through V6. Some people stays the same size, and that's known as poor R wave progression, which means you have heart disease, but most people, it will be getting bigger as you go along. Let me just show you why you look the way you do in V1, V2, V3, V4, V5, V6. You know, initially the impulses always go down the left bundle. And when the impulses are going down the left bundle, they will go across. They will go across your ventricular septum. They'll go across your ventricular septum and your anterior wall in this direction towards a positive sticky, and that's why I get an upright complex. And since I'm going away from the positive sticky V5 and V6, that's why initially it goes down. So initially, impulses go across the ventricular septum and the atrium, and the ventricular septum and the anterior wall in this direction towards the positive sticky, and that's why it goes up. Then what happens is it goes through the Purkinje fibers, right, through the right bundle, and then through the left bundle, but first the right bundle, and goes across, right, in this direction. It also spreads down the left bundle and goes across in this direction. And now the electricity is moving in this direction, away from V1, V2, V3, and that's why I have a negative complex, but towards V5 and V6, and that's why my complex should be going up, V5 and V6. So that whenever you look at V1, V2, V3, you will notice the presence of a R wave. Very important you have an R wave in V1, V2, V3, because the presence of an R wave means the presence of a very healthy and happy anterior septal wall. Because whenever the impulses go across the ventricular septum and the anterior wall in this direction towards a positive sticky, I get an upright complex known as a R wave. So whenever you're looking at V1, V2, V3, you always got to look for the presence of a R wave. Very important, R wave. Means you have a very healthy and happy anterior septal wall. If you're looking at V1, V2, V3, and then looking at V1, V2, V3, you don't have an R wave. Let's say you don't have an R wave in V1, V2, V3. It's gone. Bye-bye. No R wave, no anterior septal wall, because electricity does not go through dead tissue. So if you have an anterior septal wall MI, electricity won't go through it towards the positive sticky, you lose your R wave. No R wave, no anterior septal wall. In this case, you'll see no R wave, and the ST segment is on the isoelectric line, we infarct head. If you have ST elevations, we infarcting. So infarcting, infarct head. Here, we infarcting, because we have ST elevation. Right? So no R wave, no anterior septal wall. Where is it? Dead. Your patient? Infarcting, infarcting. Infarcting. Now, when you look at injury, right, whenever you look at injury, in looking at the leads 2, 3, and AVF, or leads 1, AVL, V5, and V6, where you're looking at the inferior or the lateral wall, you look at the isoelectric line, and when you have injury, you get ST elevation. And so what you're looking for really is a fireman's hat. When you're looking at V1, V2, V3, I don't have V4 here because I don't look at V4, but some people do. You always got to look for the presence of a R wave. If you're looking at V1, V2, V3, and you don't have an R wave, you say, no R wave, no anterior septal wall. Where is it? Dead. Your patient? Infarcting, infarcting. Because now we're having ST elevation. So really what you're looking for when you're looking for injury or MI, you're looking either for a fireman's hat or you're looking for a tombstone. That's it. Either fireman's hat or a tombstone. You know, people are like, oh, you know how to read a 12-leaf for a myocardial infarction? Hey, how many brain cells you need for that activity? You look for a fireman's hat or a tombstone, either or. And looking at this EKG, look at leads 2, 3, and AVF. What is it that you see in the inferior wall lead? You see fireman's hat. Near, near, near. So we're having a inferior wall MI. whenever you have an inferior wall MI, sometimes you'll get ST depression in 1 and AVL. We don't have it in 1, but we do have it in AVL, and that's called a reciprocal change. Notice we have R waves in V1, V2, V3, so I'm very happy. Although I'm not jumping for joy because I have ST depression in V1, V2, V3, so I do have a little anterior septal wall ischemia. But the big to-do here is fireman's hat, 2, 3 in AVF, we're having a inferior wall MI. And looking at this lead 2, 3 in AVF. Notice that in lead 2, 3 in AVF, we have ST elevation. Therefore, we're having an acute inferior wall MI. Then I look at lead 1 and an AVL and I have ST depression. But that for the first 24 hours is just called a reciprocal change. Then I'm very happy I have R waves in V1, V2, V3, so I'm very, very happy. Although I do have significant ST depression in V1, V2, V3, so I do have some anterior septal wall ischemia. But the big to-do here is the MI. It's an inferior wall MI. And looking at this, look at leads 2, 3, and AVF. What do you think is happening here? And you would say an acute inferior wall MI. How do you know? Fireman's hat's in 2, 3, and AVF. Fireman's hats. What do you call the ST depression you see in 1 and an AVL? Right, reciprocal change. They should last for about 24 hours. If you still have them after 24 hours, then it's ischemia. But you aren't happy in that you have R wave. So we're not jumping for joy because we got some ST depression. But we're happy we have R waves. But the big thing here is an inferior wall MI. And looking at this EKG, 2, 3 in AVF, have a little ST depression in 2, 3 in AVF. All right. The big to do here is in V1, V2, V3. No R. No R. No R. No R. No anterior septal wall. Where is it? Dead. Your patient? Infarcting. Infarcting. As a matter of fact, if you look at V5 and V6 and AVL, which is all the lateral wall, AVL, V5, V6, he also has ST elevations in that. He's not only infarcting his anterior septal wall, but he's also infarcting his lateral wall. It's having a massive anterior. The ST depressions you see in 2, 3, and AVF are just called reciprocal changes. They should go away in 24 hours. Look at this. No R. No R. No R. No R. No anterior septal wall. Where is it? Dead. Your patient? Infarcting. Infarcting. Because you have ST elevation. We're infarcting our anterior septal and also lateral wall, as evidenced by fireman's hats in V5 and V6. Huh. No R. No R. No R. No R. ST elevation. Fireman's hat. Fireman's hat. So another anterior septal and lateral wall MI. When you're taking care of people with MIs, you got to look for complications. On the exams, there's like 2 questions on complications. People with an inferior wall MI have a totally different set of complications than people with an anterior wall MI. When you have an inferior wall MI, you know your right coronary artery supplies the inferior wall, and it also supplies other structures. Your right coronary artery supplies your sinus node in about 55% of the time, your AV node in about 90% of the time, right atrium, right ventricle all the time, mitral valve all the time. So as a nurse, you've got to be aware of all these complications. So that the complication that comes out of the sinus node is bradycardia. And you got to watch out for that. Although you're happy when people are having inferior wall MI and they're bradycardic as opposed to tachycardic. Because tachycardia in the light of an inferior wall MI has a very high mortality rate. Now, when people are bradycardic with an inferior wall MI, they're usually asymptomatic. Usually very asymptomatic. Now, you learned in nursing school, they ask you, you know, why are you bradycardic in inferior wall MI? Like, why is the heart beating slow with inferior wall MI? And the nursing books tell you because it's the way that the heart protects itself. By beating slower, it'll use up less oxygen. Well, that's a bunch of bunk. I mean, how stupid is that? I mean, your heart has this big concern for you. I mean, if your heart has such a big concern for you, why the heck would it infarct you in the first place? So, so it has nothing to do with being concerned about your health. You're bradycardic because you're ischemic. Your sinus node is ischemic. That's why you're bradycardic. And when people are bradycardic, they can do one of three things. They can be totally asymptomatic. And so what if the guy's heart rate is 38 and he's totally asymptomatic? What are you going to do? Nothing. Just keep an eye on him. You know, he's sitting up eating egg beaters and English muffin, his heart rate's 38. Yeah, you keep an eye on him. Some people, when they go bradycardic, their eyeballs go behind their head. And they like have a code. So then you have to save them, right? And then some people, when they go bradycardic, will ring their buzzer, and when you go in there, you're like, are you dizzy? Are you dizzy? Are you dizzy? Are you dizzy? Because there's alarms going off and everything, you know, are you dizzy? And he says, well, I got a little ringing in my ears, and I think I'm a little lightheaded. You're like, ah. Well, stay away from the atropine, right? Stay away from the atropine. Oh, nurses always want to be given atropine. Your best bet is just to lie him flat, right? As long as when you take your blood pressure, his blood pressure's okay. I mean, his blood pressure, if he's bottoming out his blood pressure, then yeah, you got to give atropine. But if his blood pressure's okay, and he's ringing in his ears, a little lightheaded, you got to lie him down. Got to lie him down and raise his legs up, right? Put his legs up in the air, okay? Right, his legs, not yours. Although if you were to lie flat on your back and put your legs up in the air, you know what? That would increase the man's heart rate. Works every time. There's just something about that position that just does it. I don't know what it is. So, no, you have to lie him flat. See, they're not paying you enough money to put you on your back with your legs up in the air, right? I think they're going to raise a couple hundred for that. Now, the problem that comes out of the AV node that you got to keep an eye on is complete heart block, AV heart block, AV dissociation, call it whatever you like. But if there's any disconnection between the atrium and the ventricle, then a pacemaker must be inserted. Any kind of disconnection. I had a young guy with inferior wall MI, and he came in, and his heart rate was like 70. Sometimes it was even 80. And I didn't even know he was in AV dissociation because I'm in this room taking care of him, and he's fine. You know, how are you? How's the kids? You know, blah, blah, blah. And every once in a while, my friend's yelling, hey, Ccrn, he's injunctional. He's injunctional. So I'm looking. It looks fine to me. I'm like, yeah, okay. Hey, Ccrn, he's in lower junctional. He's in lower junctional. I'm like, lower junctional. And I look, it looked fine to me. So then I go out and I say, you know, what's this junctional business? See, it looks fine to me. So we get a big long strip, and I get an index card, and I make a dot where the, you know, R to R's are, and the P to P's, and I go like this. And after a while, I start seeing the P waves going into the QRSs. You really couldn't notice it, though, because his heart rate was like so fast, you really couldn't notice. But like every once in a while, 2 beats, one had the P wave like going into the QRS, and then the other one had the P wave after the QRS. And then all of a sudden it would look normal again. So if you didn't look up at the right time, you were missing it, you know? But he was definitely in AV dissociation, but just interesting. It was like, hey, Ccrn, your patient's injunctional. Really, if the guy was injunctional, the P wave wouldn't be upright. This P wave is upright. It would be inverted, right? But anyway, whenever you have someone with inferior wall MI and they have AV dissociation, no matter what the heart rate is, a pacemaker must be inserted. So I know that when I called up this doctor, I knew that when I called him up at 4 o'clock in the morning to tell him that, you know, this 30-something-year-old guy, inferior wall MI, needs a pacemaker, I know he would say to me, well, wait till, you know, I'll be in the morning. I know he was going to say that. So that's why that's why when he said to me, what's his heart rate, I couldn't tell him 80, because then he would never come in. So I'm like, 20, 20, 20, 20. He's like, oh, I'll be right in, have a pacer already. So then when he shows up, he was like, where's the strip? Give me the strip. Let me see the strip. So they gave him the strip, and he's looking at it. He was like, hey, you told me 20, this is, 80. I'm like, I said 20, 20, 20, 20. It comes to 80, I didn't even lie. It comes to 80, might as well put a pacer in. And then the problem that comes out of the right atrium and the right ventricle is a right ventricular infarct, right? Right atrium, right ventricle, right ventricular infarct. Whoop. And you could spot that by doing V1 through V6 on the right side, you do it on the left side, V1 through V6, but also do V1 through V6 on the right side, and you see ST elevation, and that means right ventricular infarct. And then the problem that comes out of the mitral valve is mitral insufficiency. When dealing with anterior wall MIs or anterior septal wall MIs, you need to know that your left anterior descending supplies your anterior septal wall, but also supplies other structures. It supplies the bundle of His and the bundle branches and the ventricular septum. Now, when you're looking at the complication coming from the bundle of His, it's a Mobitz 2. And what comes out of the bundle branches that you have to watch out for is a right bundle branch block. Should your patient develop either a Mobitz 2 or a right bundle branch block, it's a 94% mortality rate. Unless a pacemaker is inserted and it drops down to 14%. Good save. The problem that comes out of the ventricular septum is a ventricular septal defect. And this is what you got to watch out for, especially for a right bundle branch block. Your patient with an anterior septal wall MI develops a right bundle branch block, mortality rate 94%. Put a pacemaker in, drops the mortality rate down to 14%. Oh, and now, well, it's like 10 after 10, so I have a little break.